Welcome to the Medical Nursing Podcast, the go-to show for vet nurses and technicians passionate about internal medicine. I'm Laura Jones, a registered vet nurse, all-around medical nursing nerd, and your guide to breaking down complex medical diseases into simple, actionable chunks. Each episode is packed with knowledge and tips that you can start using right away to give even better patient care. So let's get started. Hello, and welcome back to the podcast, or a big welcome to you if this is the very first episode of the podcast that you are listening to. You are tuned in to episode 123 of the Medical Nursing Podcast, where we chat all about how we can use more of our knowledge and skills as veterinary nurses and technicians while caring for patients who often have quite complex medical conditions. This is the third episode in our endoscopy series, and in it we are talking all about upper airway endoscopy, or as it's probably better known, rhinoscopy. Now, rhinoscopy is a common procedure performed in patients with nasal discharge and nasal disease, so think things like sneezing, epistaxis, foreign bodies, etc. And just like any other endoscopic procedure, there's lots for us to think about when nursing these patients. And with that, lots of skills that we can and should be using in the process. Today, we're going to have a look at what those skills are and just how much our patients benefit from our support throughout the procedure and beyond. We'll talk about what happens during a rhinoscopy, the equipment that's used and how it's managed, and the most important considerations for us when nursing these patients before, during, and after the procedure. You will leave the episode ready to assist with these procedures confidently, with new skills to put to use. So let's waste absolutely no time and get stuck straight in. Now, rhinoscopy is a procedure with a lot going on, and for me personally, that's why I think our role in it is quite underrated. When I worked in general practice, my role assisting with scopes was basically setup, cleaning, and anaesthesia, and that was it. We didn't have the luxury of multiple nurses, for example, so often I was juggling trying to monitor my patient and help the vet with things like holding the head, collecting biopsies, troubleshooting the scope, and whatever else they may need. We had a rhinoscope. We had a set of 3 rhinoscopes. They lived in a lovely box on the shelf and they were very rarely used. Most of the time, we would look at the back of the nose with a bronchoscope, or maybe we'd have a cat come in with a grass blade and we'd anaesthetise them and have a look and fish it out with a spay hook, and that was pretty much it. And I didn't realise how much I could actually do as a veterinary nurse to support these patients. And in reality, I now know that there are so many skills that we can use while caring for these patients. And for us to do that, we first need to understand what a rhinoscopy procedure involves. So put simply, rhinoscopy is where we use an endoscope to image the nose. Now, it's not as simple as that. The nose isn't the easiest place in the world to examine. It's actually a really small space, and inside it there is a lot happening. So if we look at the nose itself, the nasal cavity is full of turbinates. So our turbinates are lots of tiny, delicate, little kind of fragile scrolls of bone covered in mucosa, and the function of these is to warm and humidify the air as it is breathed in. Now, as well as doing that, these turbinates naturally will create lots of kind of narrow, blind-ending channels, and that can be really difficult to navigate through with an endoscope. On top of that, the nose is really vascular, and so all of this means that our clinicians or our endoscopists are having to manoeuvre through a very small, bony, blood-rich space that is full of kind of hidden corners. It's a bit like a maze. And that is why, one, the procedure can be technically challenging, but also why foreign bodies, fungal plaques and other abnormalities can also be really difficult to find because they can kind of tuck away in those little corners. And it's why the procedure itself carries a high risk of bleeding. And this is something that we do need to be aware of and have made a plan for ahead of each rhinoscopy procedure. Rhinoscopy gives us the only direct visualization inside the nose. So we use rhinoscopy to examine the nasal cavity itself. So this is the rostral aspect of the nose going up the nostrils. The choanae, which is the openings at the back of the nose, and also the nasopharynx, which is the region above the soft palate. So that's kind of the back of the nose inside the mouth. In In some patients, we can also actually reach the frontal sinuses, which are the kind of bony, air-filled spaces above the nose as well. And as well as visualisation, we can use rhinoscopy to collect guided samples, to flush the nose, to remove foreign material, and also to do things like apply targeted treatments where it's needed. There are two directions that we can approach the nose from, and in most cases, both are performed together as part of like a full or comprehensive assessment of the entire nose. So first of all, we have caudal or retrograde rhinoscopy, which is also referred to as retroflex nasopharyngoscopy. This is where we examine the choanal and the nasopharynx. It's performed by inserting a flexible bronchoscope into the mouth, retroflexing it back on itself and kind of hooking it over the soft palate so that we are looking at the nose from behind. That's usually performed first, and then we move on to anterior or antegrade rhinoscopy. And this is where we image the front of the nose. To do this, we're going to take a rigid endoscope, place it into each nostril, and systematically examine each area of the nasal cavity. In most cases, we will also be using continuous saline irrigation to flush the nose and do things like clear away any mucus or little bits of bleeding from where the scope has kind of come into contact with the mucosa, and that will help us to visualise the tissue and the structures underneath kind of all of that mucus and kind of horrible discharge sitting there. When we are performing a complete rhinoscopy, we always start with that retroflex view and then move on to the antegrade view. And that's important because if we start with the antegrade view and then look at the retroflex, we don't know if things like fluid and blood that might be sitting in the nasopharynx was there to begin with and it's part of the patient's disease, or if that is iatrogenic and we've actually caused that during the first part of the procedure. So we do that complete assessment, and depending on the individual patient, we may collect samples as needed. This is usually blind biopsies from the nose, so antegrade, where we pass biopsy forceps into each nostril and collect our samples. The reason that we tend to do blind biopsies versus guided ones through an endoscope channel is because that channel is really, really small, and so it's hard to get good quality biopsies in that way. Once we've collected the samples and done the assessment, the patient is then recovered. So that's the procedure itself. And then if we move on to our patients that actually need rhinoscopy and the indications for it, they're pretty much similar to the other endoscopy procedures that we've discussed in that we're not scoping these patients as a first-line diagnostic unless we're doing something like removing a foreign body. So these patients will have had physical examination, blood work, probably some imaging before we are going ahead and reaching for a scope. So rhinoscopy is indicated in cats and dogs who have things like chronic sneezing or reverse sneezing, chronic nasal discharge, stertor or stridor, and epistaxis. And the things that we are usually looking for are foreign bodies such as grass seeds, fungal infections, so things like aspergillosis, for example, which is usually associated with plant material, and also nasal tumours. Nasopharyngeal diseases such as stenosis, which is narrowing of the nasopharynx, or polyps are also relatively common, especially in cats. And in the absence of specific abnormalities we can actually see with our eyes during the procedure, we may be left with something like a diagnosis of chronic rhinitis, which is where we have identified on biopsies non-specific inflammation within the nose where there's no other kind of identifiable cause. Examination findings that raise our suspicion for nasal disease include things like unilateral nasal discharge or changes to nasal airflow patency, or potentially discharge which is bilateral, maybe started unilateral and then progressed, facial asymmetry or facial pain, nasal depigmentation, so we can see this with fungal infections, for example, or clinical signs that are not responding to appropriate treatment so far. But as we said, usually in most cases before a rhinoscopy, we have performed some of those other kind of first-line diagnostic tests. These include routine blood work to assess things like general health, to look for non-nasal causes of bleeding. So if we've got an epistaxis patient, for example, we want to make sure we've looked at haematology, checked platelets, coags, etc. And of course, if we are then moving on to a scope, these routine bloods that we've done are going to help us with kind of anaesthesia risk planning as well. We also need to perform coagulation testing in most cases. That's regardless of whether they've had epistaxis or not. So if they are going for rhinoscopy, they probably need coags, or at least as a minimum, platelets plus minus a buccal mucosal bleeding time. Now this is important because alongside the fact that we have patients that present with epistaxis and we need to investigate why that's happening, we also know that bleeding is a significant complication of a rhinoscopy procedure. So we need to make sure that our patient has sufficient platelets and potentially also normal clotting times, so APTT and PT, before we go ahead and do something like put a scope up the nose or take biopsies from the nose. Other diagnostics that are commonly performed include blood pressure assessment, because hypertension can actually cause epistaxis, and likely some sort of diagnostic imaging, which is usually a CT scan of the head. I also want to talk about when rhinoscopy is contraindicated or when there are kind of more risks or special kind of considerations for rhinoscopy, and our role in identifying and minimising those risks as veterinary nurses. This is important because, yes, okay, our vets are going to be making decisions about what procedures are done, but we are monitoring these patients, and so we need to be able to kind of confidently identify some of those potential risks and think about that with our monitoring plan. So firstly, any patient that has a bleeding disorder or a hemostatic defect should not undergo rhinoscopy because, as we've said, the nose is highly vascular and bleeding is a significant risk. Where this can be a bit challenging is patients that have nasal tumours. These guys present a real challenge for us during their procedure because we need to do a rhinoscopy for diagnosis. We need to take samples of that tissue and potentially debulk that tumour if we can. However, many nasal masses are highly, highly vascular, meaning that we have to scope them even though we know bleeding is going to be a big problem. This is where having something like a hemorrhage management plan comes in, and also where our role as veterinary nurses and technicians in identifying risks and planning mitigation strategies is vital. So I would really recommend, if bleeding is a significant risk, have a hemorrhage management plan that you have discussed with your vet, and we'll talk in a little bit about how we can do that. In many cases with these nasal masses, we will use things like endoscope guided laser to actually cauterize the vessels so that whilst we are sampling and debulking the tumour, we can actually go in, target those vessels with the laser and kind of cauterize those at the same time, minimising the bleeding risk. Another area where we need to be very careful with is when there is evidence that the patient's nasal disease has broken through the cribriform plate. So the cribriform plate is a thin perforated plate of bone, and it kind of sits like on the floor of the nose and it separates the nasal cavity from the brain. Patients that have destructive nasal diseases, which is usually one of two things, fungal infections or tumours, can actually have it where that disease process has started to kind of eat through that bone. And when that happens, there will be some degree of communication between where we are scoping and the brain. So that is an incredibly kind of risky procedure. We need to be very careful about monitoring for neurological signs in recovery, for example. Looking at contraindications, rhinoscopy is also contraindicated in patients that have increased intracranial pressure, so increased pressure within the skull. And this is because we are potentially going to increase that further by causing sneezing, because even if you've got a well anaesthetised patient during a rhinoscopy, sometimes they will do a little bit of kind of reactive or reflex sneezing. And of course, we are also instilling fluid within the nose, potentially causing bleeding. So this is an additional challenge. Now, of course, we've already mentioned none of this, so whether these procedures are performed or are not performed in those specific patients is our call to make as nurses and technicians. We know that that decision lies with our vet, but we still need to be aware of those considerations because it's going to impact our approach to these patients, it's going to impact how we prepare for their procedure, what we monitor for, and much, much more. This episode is brought to you by the Foundation Award in Medical Nursing. The Foundation Award is my very own 12-month on-demand course designed specifically for veterinary nurses and technicians who want to feel genuinely confident nursing their medical patients. If you've ever felt overwhelmed by a complicated case, or like you're just ticking boxes on a hospital sheet rather than truly understanding what's going on with your patient, then this course is for you. The Foundation Award goes beyond just throwing information at you. It gives you a real framework for turning your knowledge into hands-on, patient-centred nursing care that really uses your skills. You'll work through it in your own time with live case-based support built in, so you are never learning on your own. If you're ready to go from feeling stuck to leading care with confidence, then head on over to the website and check out the Foundation Award. You can find the link in the show notes. And now, back to the episode. So speaking of those complications, what I want to talk about now is how we directly support these patients as veterinary nurses, both before, during, and after the procedure. I have already mentioned that there is a lot that we can do to care for these patients. So what I want to do now is talk you through what they need from us, and with that, the skills that we can put to use in the process. So firstly, before the procedure itself, we need to be careful in how we approach and handle these patients. Because if we think about many of the patients we see with nasal disease, they are often dealing with things like reduced airflow and some degree of nasal obstruction. In my experience, this can make them panic, it can make them quite head shy, it can make them resentful of handling, and one thing I do find is it can make them especially intolerant of having their neck extended, because that can make them feel like they are kind of even more obstructed. If you imagine having a really, really blocked nose and then trying to breathe through your nose only with your head all the way up, looking up at the ceiling, it's harder. And our patients are going to be experiencing the same thing. So if you are doing things like blood draws, I would personally, if you can, avoid things like jugular sampling, because you may find that your patient panics when you try and extend the neck up for a jugular. So actually maybe we decide we're going to take blood from a limb, or we place an IV and get bloods that way, for example. All of this means that careful handling, minimal restraint, and working with your individual patient's preferences is vital. We also need to assess bleeding function, as we've already mentioned, as well as neurological status, and perform a thorough pre-anaesthetic assessment so that we can do things like ASA score our patient and identify any increased risks associated with their specific procedure. Then we have got the procedure itself, and there are a few specific things that we need to look at aside from our general kind of anaesthesia support and monitoring. So the first one is aspiration. This is important because we are continually flushing fluid into the nose during an antegrade rhinoscopy procedure. This means that the ET tube should be appropriate for the patient's airway size. If you are using a cuffed ET tube, then that cuff should be double checked at various points throughout the anaesthetic. The whole system should be checked for leaks, and we should be using throat packs. And with that, making sure that we are paying attention to how many throat packs have gone in and making sure that they have all been removed before the patient recovers. We should also be auscultating the chest regularly as well, listening for crackles and keeping an eye on your end-tidal CO2, because one thing that you can find is that flushing solution can get sucked up the water trap, and that can impact the accuracy of your end-tidal CO2 monitoring. The next consideration is bleeding. So one thing, especially if you've got a patient who's high risk of bleeding, that's a good idea to do is check the volumes of blood that have been lost as far as you possibly can. Now, during a rhinoscopy procedure, we are instilling saline through the nose. So some of the fluid that comes out of the patient is going to be saline and some is going to be blood. But if we know how much saline has gone in, then it gives us a good indication of kind of how much blood the patient is losing. We shouldn't expect it to be very much, but in those high-risk patients, it's worth keeping an eye on. Also with that, looking at cardiovascular parameters under anaesthesia, monitoring for, signs of hypoperfusion, for example, so heart rate changes, blood pressure changes, etc. Analgesia is another important one. So we know that patients can be quite reactive during rhinoscopy. It's not necessarily a really painful procedure, but if you imagine how sensitive your nose is, anything being in there, even in a well-anaesthetised patient, can be quite stimulatory. So multimodal analgesic protocols and things like nerve blocks are really, really good for these patients. And in fact, that's an area for us as nurses and technicians that we can get involved in. Where I tend to work, the nurses are doing pretty much all of the nerve blocks for these patients. So infraorbital nerve blocks or maxillary nerve blocks, where appropriate, under veterinary direction, can be a fantastic way to provide additional analgesia and a max sparing effect for these patients. In terms of preparedness for complications, I would also personally advise having a few items on hand throughout the procedure and into recovery, just to make the procedure safer and also help us be prepared should any complications arise. So the first one is suction, so a suction unit, suction tubing and a flexible suction catheter. The second one is a laryngoscope and large cotton buds. So this can help us clear blood, mucus and fluid from around the larynx prior to extubation, for example. And the other thing is that hemorrhage action plan where one is needed. So a hemorrhage action plan is usually something that we will prepare in advance for patients where we know that bleeding is going to be a really high risk for that patient. So that might be something like a really big nasal tumour, for example, or a really long procedure, or a patient where we think that there may be a degree of bleeding disorder as well that needs to have a scope and it's not possible to delay it. So this hemorrhage action plan includes things like pre-calculated doses of medication to assist with hemorrhage. So tranexamic acid, for example. Another one is a tamzolate, which is hemociliate is the trade name. And there's also devices in the event of really severe hemorrhage that if you do a lot of rhinoscopy, perhaps if you're in referral practice, I would advise keeping in, and these are called rapid rhinos. So what these are is basically inflatable balloons that are covered with a cellulose sponge type material. And what you do is you put these into the nose and you then inflate the balloon, and that will pack the area in the event of severe hemorrhage, and the kind of cellulose sponge that's covering the balloon turns into a gel in contact with fluid, and it helps to prevent bleeding. It's a bit like a Liastipt that they use in surgery, but up the nose instead of in the surgical site. So those are a good thing to keep in stock if you do a lot of rhinoscopy in practice. And our nursing care, of course, continues into recovery. So in recovery, patients should be continually monitored for complications associated with aspiration of any fluid under anaesthesia, bleeding, pain, and in some cases, neurological signs. A bit of sneezing is normal. There's also potentially going to be some residual bleeding, especially if you've got a patient who's sneezing lots, because they might dislodge a few little blood clots that have formed at the end of the procedure, for example, but this should be pretty short and self-limiting. If we have ongoing epistaxis, hours after the procedure, or the patient's losing large volumes, that's when we might need to worry. So as well as nursing the patient themselves, another big part of our role is preparing, handling and processing the equipment. So I want to finish up by talking about the scopes themselves. So we use two different endoscopes during a rhinoscopy procedure. Firstly, we have our flexible bronchoscope, as we discussed in last week's episode, 122, and this is used for the retroflex view. And then we have a rigid metal telescope, which is used for the antegrade view. And both of these scopes are going to be connected to things like a camera head and a light cable, and then to the endoscopy tower itself. The telescope that's used is usually an angled rigid telescope, so it usually has a 30-degree angle on the end. And that actually allows the clinician to get a wider field of view, because what they will do is inside the nose, they will rotate that telescope around, meaning that they can actually see more of the nose. The telescope is placed inside a working sheath, and that sheath has ports on it where we can do things like attach a fluid line, attach a syringe, and pass instruments. The telescope is incredibly delicate and it needs to be handled with extreme care to prevent cracking or even things like small knocks on the end, which can easily impact image quality. It should also not be inserted into the nose outside of that working sheath, and whenever it's not in use, it should be stored in a plastic protective cover. So there's usually a little kind of perforated plastic sleeve that can go over that scope. So if it's being soaked or cleaned or anything else, it can have all of that done whilst being in that protective cover. Beyond the scope itself, there is also a lot of ancillary kit required for endoscopy. So this includes biopsy forceps, so both those flexible cup type forceps that actually go down the channel of the sheath, and also rigid ones that can be passed alongside the scope blindly into the nose. We also have grasping or foreign body retrieval forceps, sample pots, mouth gags, and things like throat packs, for example. There's also a lot of fluid needed for this procedure because, as we said, we use often continuous saline irrigation throughout rhinoscopy. So to do this, we will use 0.9% sterile saline. The bigger bags that you can get, which are usually sort of 2 to 3 litres, can be really, really helpful here, especially if you've got a really big patient or a very long procedure. And that should be attached to a giving set and placed inside a pressure infuser, which is basically like a massive blood pressure cuff that goes around the bag that you can pump up to squeeze the fluid into the patient quickly. We want to make sure that this saline is warmed, because if we are continually lavaging the nose with cold saline, that is going to contribute to hypothermia. And the other thing it will also do is fog up your clinician's scope, which means that they won't be able to see properly. And just like with the GI scope and the bronchoscope, as we've talked about earlier in the series, all of this kit needs to be prepared and double checked before the patient is anaesthetised. So our flexible bronchoscope is going to be prepared, cleaned and maintained, just as we've already discussed earlier in the series. Things like leak testing, white balancing, and then careful cleaning in high-level cleaning and disinfectant solutions. The rigid scope is cleaned in a similar manner. However, there is no leak testing needed for this scope. That's exclusive to flexible scopes only. I do want to mention though, some rigid endoscopes are going to be autoclavable. So some of them will actually say on them that they can be autoclaved. However, traditional kind of normal benchtop autoclaves can be damaging because some of them will have kind of heating and cooling cycles. And if we overly heat the telescope, it might be that it's prone to cracking, for example. So what I would personally recommend is always double check with your scope manufacturer whether the particular model of autoclave that you have is okay for your rigid scope. If you have access to EO sterilisation, that's usually preferred because it is safer for the equipment and it removes kind of some of those concerns. Another thing that we are going to be doing during a endoscopy procedure is collecting and processing samples, and this is another important aspect of our role. And just like we discussed earlier in this series back in episode 121, how we handle and process our samples directly impacts their diagnostic quality, and with that, the answers that our clinicians get from the lab and the patient's diagnosis. So while sample processing may seem like quite a basic nursing skill, how we do it is actually really important. So samples should be collected carefully from our rhinoscopy patients, usually blindly, as we've said, because we get bigger samples that way, using unspiked oval fenestrated forceps. Once we've collected the sample, it should be either rinsed or shaken off of the sample cup of the forceps into a pot of saline, rather than kind of teased off of the forceps with a needle. This can damage actually both the forceps and the sample. At the end of the procedure, the sample should then be kind of potted up in the required container as needed. So histology samples should be placed in formalin, ideally on something like a cell-safe container, which are the little cassettes, the mesh cassettes that the small samples can be placed in. And also culture samples are often collected during rhinoscopy as well. This might be a bacterial culture, a fungal culture, or both. And if your clinician wants a culture performed, a sample, so one of the biopsies, should actually be sent off in a plain tube in sterile saline. So this is an unfixed sample. What I would personally recommend is taking one of the smaller, less good quality samples and using that for culture, because it's not going to impact the culture results that your patient comes back with. But what it will do is if that sample went off for histology, it wouldn't be as diagnostic. So prioritise the bigger, better quality samples for histology, and the ones that the clinician is not quite so happy with, send those for culture. And also, when we are sending these samples away, include a complete history, an overview of the clinician's endoscopy findings, and things like the CT report if your patient has had a CT scan. This is essential because it's going to help the lab accurately comment on the sample and improve the diagnostic information that we get back from the lab in return. So as you can see, our role in rhinoscopy is so much bigger than just monitoring the patient and setting up the scope. Now, today's episode was another detailed one, so I really want to leave you with the key points from everything that we've chatted about kind of last so that they're fresh in your mind, and of course the nursing skills that you can use with your own rhinoscopy patients in practice as well. So rhinoscopy is the direct visualisation of the nose, so the nasal cavity, the choane and the nasopharynx. We use it to investigate things like chronic sneezing, discharge, epistaxis, potentially fungal disease, foreign bodies, tumours, polyps, among other things. Usually these patients will have had blood work and imaging first, and we need to make sure that we have assessed haemostasis, so checked platelets, checked coags, maybe done a buccal mucosal bleeding time. And where we think that bleeding is going to be high risk, we have created that action plan before going ahead. Our role in nursing these patients is vast. It involves careful pre-anaesthetic handling and support, checking blood work, collaborating with the vet on tailored anaesthesia planning, performing nerve blocks, monitoring these patients really closely, and much, much more. We're the ones who are setting up and handling the kit, processing the samples, counting the throat packs, protecting the airway, monitoring for bleeding, and generally using as many of our skills as we can to make this a safe and successful procedure, both for our patients and for our entire team, which is exactly why the importance of our role in this cannot be overestimated. So that is everything I have for you in this episode. I hope that this has been a helpful refresher and overview of rhinoscopy, and given you some food for thought on how we can use more of our skills to make a difference with these patients. In particular, nerve blocks are a fantastic thing and a quick, easy, practical nursing win that we can use to really improve things for these patients. So if you're not performing those already in practice, I would definitely recommend talking to your vets about learning to and starting to do them. Don't forget to share this episode with a colleague, pop it in your practice group chat, send it to someone who would benefit from it. Pop me a message on Instagram, let me know, are you doing rhinoscopy in practice? If so, what does your role look like right now? What are you not doing that you would like to start to? I love chatting to you and helping you use more of your skills in practice. So pop me a message and let's have a chat about it. That just leaves me to say a massive thank you for being here and for choosing to learn with me for another week. Have a fantastic week, and I will speak to you very, very soon. Bye. If you've made it this far, then thank you so much for listening all the way to the end of the episode. And I have one more thing to ask of you before you go today. I would love to hear from you. Yes, you. I love hearing about the cases that you're seeing, the skills that you're using, and the conditions that you want to learn more about. Drop me a DM on Instagram. I'm at Vet Internal Medicine Nursing, and don't be shy. Come on over, say hello, and tell me a bit more about you. Talk to you soon.